right. Hello, hello. Hold up. Let me clean up the camera just a tad. But yeah, hello, guys. So this is just gonna be a study with me. Like, I don't know how I'm gonna do this, but right now I need to study for Patho Farm, and I kind of need a bit of motivation. And me personally, I like talking to people, so I'm just gonna talk to the camera as I'm studying. Also, these glasses are dirty. I'm not gonna lie. I need to clean them. But yeah, so I'm starting from Patho Farm. I am really going over like my meds mostly because whatever meds I need for heart, so like anything to do with heart. So like our not lecture, our exam is going to be like on heart failure, the different types of shock, hypertension. So just anything pertaining to do with that, and any medication that will be can be given for those things. Also, what else? Coronary arteries disease, cardiac arrhythmias. Yeah, so VFib, AFib, aflutter, VTAC, all of that stuff. And I also need to go and look back at the medications for the different arrhythmias, but we digress. So let's start. So the first card I have here is, and I suck at pronouncing these names, prazosin. Prazosin. So this is the first one. It's not like super dark because I just used like a gel pen. Should have really used a Sharpie, but whatever. So prazosin, for this one, eep. So prazosin. So if it's a zosine at the end, I know it's going to be selective vasodilator, and zosins are specific for arterioles and my veins. They also are are what alpha 1 blockers, and they're mainly used for hypertension. Like, so my prazosin, that's what it is. That's all I have written on the card. She didn't mention any adverse effects or any drug interaction, so not gonna stress that. I do for the other one. So the next one I have is hydralazine. So hydralazine is going to be used in hypertensive crisis. So this is like a first line drug for hypertensive crisis. So very important. It is a selective vasodilator. It is more selective for the arterioles than the veins. What else do I know about hydralazine? Hmm, hydralazine. Oh, it causes a lupus like rash basically. So we would not give this to patients who have lupus. And it also causes reflex tachycardia because it works really fast. So it has a fast onset and it works really fast to vasodilate, and because we're vasodilating very quickly, our blood pressure drops rapidly, so we get reflex tachycardia. Yep, and that's what hypertensive crisis, hypertension, it causes a reflex tachycardia, like I said, and the lupus, like systemic lupus erythematosus like syndrome. So yeah, those are the things for hydralazine, and we would use it in emergency. Hi there, Tony. Oh, this is a fun one. So this is minoxidil. Minoxidil. Apparently, you hear this on commercials. I've never seen a commercial for it, but this is a drug that's used for hypertension that was originally meant. Oh, it's a drug that's used for hair growth. So if you experience hair loss, you can use this. But the original intention was for it to be a hypertensive drug, but the adverse reaction was hair growth. So now it's also used for hair growth, but it is a selective vasodilator. And minoxidil is more selective just for the arterioles, just like my hydralazine. Oh, and it causes a decrease in the cardiac afterload because I'm decreasing the pressure in my blood vessels. Yeah, so that's really it for this one. There are no other adverse effects really, and it doesn't have any drug interaction, right? So the next one, like all my pink cards are like in the same category, but like that was not intentional. So the next one, again, this is nitro, right? Nitroprusside. So this also is another selective vasodilator, but this one works on both the arterioles and on the veins. It works very fast when you give it IV. This is going to be again used in emergency situations, so hypertensive crisis. And then what else did I have for this one? This one does have toxicity. The adverse effect is that you get excessive hypotension just because it works so well. Your blood pressure can drop really low, and we do not want that. And the other thing with this, with nitroprusside, is that it can cause toxicity if it's used continuously for 2 to 3 days. If you have continuous IV infusion for 2 to 3 days, you can develop toxicity, which will be cyanide or thiocyanate, right? That's what it is. Thiocyanate toxicity or cyanide poisoning and excessive hypotension. Yep. So you would only use this for short-term uses. You would not use nitroprusside for long-term uses. Great. I'm happy because I was still a bit like iffy on some of those, but I'm like, I'm getting them down. I'm so happy about that. So the next one is my Enalapril. Enalapril. I don't even know how to pronounce these things, guys. Do not judge me. Don't judge me. But this one, because I see pril at the end, I know it's an ACE inhibitor. So ACE inhibitors are angiotensin converting enzyme inhibitors. So prevent angiotensin 1 from becoming angiotensin 2. And because of that, we do not get the release of aldosterone, and we do not get systemic vasodilation. Hi there. Hello, hello. So we don't get the systemic vasoconstriction that we would get with aldosterone. And my ACE inhibitors do increase my bradykinins, which is why the adverse reaction for this is that it can cause angioedema, right, which is like that anaphylactic like response where like your throat swells up. So it can cause angioedema. It can cause fetal harm. So you would not give this to someone who's pregnant or thinking about becoming pregnant, right? So fetal harm, angioedema to the adverse effect. It can cause hyperkalemia as well. What else are my pills known for? It gives you a persistent cough, and a lot of people switch off of ACE inhibitors for this reason. Because of that persistent cough, it will keep you up at night. So they'll take you off the ACE inhibitors and probably give you something like a sartan, which is my ARBs, and because those don't give you the cough. Hi there, hello. For ACE inhibitors, these are going to be used for hypertension. They're going to be used for heart failure, myocardial infarction, and the last thing that they're used for is, there's a fourth one. Oh my gosh, oh my gosh, oh my gosh. What's the fourth one again? I'm gonna flip the card over and I'm gonna be so annoyed at myself. Nephropathy. But yeah, hypertension, heart failure, myocardial infarction, nephropathy. Oh, for the drug-to-drug interaction for this one, it does have a few drug-to-drug interactions. For my ACE inhibitors, we do not want to take it with diuretics. We don't want to take it with other anti-hypertensive agents. Nothing that can increase my potassium level, and we also do not want to take it with NSAIDs. So we do not want to take like any ibuprofen or naproxen with this, because they both work at the level of the kidney, and they're both kind of working in opposition. So like you have that drug to drug interaction, right? So diuretics, hypertensive drugs that raises my potassium. Oh, and I forgot lithium too. Yeah, so those are my drug to drug interactions. I did get all of my adverse reactions, so yeah, which is good. It's good. Oh my god. Whew. Okay, so next one we have is nitroglycerin. So nitroglycerin is the drug class for this one is the fact that it's another selective vasodilator, more specifically for my veins than my arterioles. It's also considered anti-anginal, so it's mainly used is for angina, which yeah, so hypertension and angina are the two things that I'm really going to be using this for. Stable and variant angina, not unstable angina. So yeah, this works by causing vasodilation and by allowing more blood to return back to the heart. um what else? Nitroglycerin, the adverse reaction with this one is that you can develop a tolerance for the drug where it no longer really works as effectively for you. So you do want to limit the use of it for when you actually really need it. And you can also develop cross tolerance to other nitrates. So really want to monitor your use, and that's important in patient educating. Um, the drug to drug interaction is the fact that it can cause the cross sensitive with other drugs as well, like I mentioned. The key thing within this thing as this drug is that if I see, right, I've taken it 3 times within 5-minute intervals of each dosing, which will be like a total of 15 minutes, and it's not working, call 911. You are probably having a myocardial infarction and not angina, and you need to go to the hospital. So, yay. Oh, I didn't say, oh, it does have other adverse reaction. My bad. So headache, orthostatic hypotension, reflex tachycardia is also seen with this. Okay, I'm gonna put this over here because I need to go back over it because I missed those couple things. like I said, this video, like the title says is study with me, so I'm really just studying, guys. And for if you're interested in what I'm studying for my pathopharm exam, which is tomorrow. And for this exam, we've been for like the topics that we're covering, looking at the heart. So we're looking at everything related to the heart failure, hypertension, not stroke, myocardial infarction, heart attacks, shock, different types of shocks, and cardiac dysrhythmias, coronary artery disease, and all the medications. So I made these are mostly the medications, like the different drugs that you can take for various like heart issues that I'm reviewing, because I know these are going to be on my exam and I need to know them like the back of my hand. And this exam is tomorrow, guys, at 7:55 a.m. So yeah, that's what I'm doing. So this next one says drugs for angina. So the different drugs that we're taking for angina are going to be my nitroglycerin, which I talked about earlier, just put off to the side, my calcium channel blockers, and my beta blockers. So my nitroglycerin work by causing vasodilation, and it's going to increase blood flow back to the heart. So that's also going to help with increased oxygen, right, tissue perfusion. And then calcium channel blockers is going to allow my heart to not increase my heart rate, not increase the contraction, and is also going to help with preventing vasoconstriction. So that's also how that works. And then we have beta blockers, which is very similar to calcium channel blockers. And what they do, it prevents my heart from increasing the heart rate, increasing the contractility, and help with decreasing the resistance. So that's gonna lower my blood pressure. Yeah. So and then we have a fourth one, rasolazine, which is really not that important. It's just that we would use it in combination with any of the other ones if the other ones are not working on their own effectively. Okay, my biochemical markers for myocardial infarction. For when I have a heart attack, these are things that I'm going to see in my blood. I have a heart attack, a person's having a heart attack. Released when we cell death. So when my heart muscles die, they release troponin. So when that troponin levels are elevated, that tells me that muscle tissue, muscle cells have been broken down. So very important to like just look for those labs. Myoglobin is another one, and this is the first one you're going to see because they're seen within the first few hours of a heart attack of those tissues dying, and they are only present, they return back to their normal level, like they drop it down within 24 hours. So I see hemoglobin only has a 24-hour window, right? So it means this person is having just had a heart attack. The troponin level, they go back to normal in 2 weeks, but you can have a heart attack and like I'm seeing troponin levels a week after the fact. So that's why both of them are really important. There's two other biomarkers, which are creatinine kinase and lactate dehydrogenase, which those usually peak within the blood 3 to 12. I want to say 3 to 12 hours after the onset, and they usually return back to normal like within like 14 days to like around like 2 weeks each as well. Oh no, creatinine kinase is quicker. It's like 2 to 3 days, but the lactate dehydrogenase is 14 days. Same as troponin is 14, like 2 weeks. So good to know. But yeah, knowing my biomarkers, guys. And once again, y'all know I am a nursing student, so as always, yeah, it's rough out here in the trenches, guys. It's rough. So next one, again, we're kind of on a like heart attack, myocardial infarction kick right now. The next one is also about it. So it's secondary prevention of STEMIs. So STEMI is a ST elevated myocardial infarction. So this is what most people are thinking of when they think of a heart attack. Like this one is very more severe. You have a non-STEMI, which is a non-ST elevated, less tissue is damaged. Yeah, it's just a less severe because you have less damage to the heart versus a STEMI. That is like the main difference, is how much of your heart is being damaged. So with this, to prevent a secondary, like a second myocardial infarction, they're going to give you drugs. You're probably going to be on these for the rest of your lives. There's 4 drugs. So the how I'm remembering this is BAAS. So B is for beta blockers. A is for, well, the first A is for ACE inhibitors. The second A is for anticoagulants and antiplatelets. And then the S is for statin. So these are all doing something slightly different to help prevent you from getting another heart attack. So yeah, I could go in detail as to why, but I'm not going to for the sake of time. But just knowing that these are just going to be lifelong preventative drugs that you are on to prevent another heart attack. Is Mona B. So M for nitroglycerin, A for aspirin, 325 milligram. That's being chewed and swallowed. You're not just going to swallow it, you're chewing it, and then you're going to swallow it. That's very important to remember. A beta. So usually you're not using all of these things. You might be using a couple, but these are the main things that they're going to be using, main drugs. Also, we can do reperfusion therapy, which is very important. You want to get blood flow back to the coronary artery that became ischemic, right? So they will do this by giving a fibrolytic, which is a clot buster, um, in conjunction with a anticoagulant, and also that you can get platelets, which would be like aspirin plus another antiplatelet, which I don't know how to pronounce the name, so I'm not going to try. So those are the things that we would do to treat an myocardial infarction. And with that, if you're giving the thrombolytic, the clot buster, you want to monitor for bleeding because it causes bleeding and you don't want the person bleeding out to death. Yeah. Okay, now we're gonna get into some other drugs. So these are a lot more drugs. Oh my gosh, I'm doing really good, guys. There's only like one I feel like I need to really review back over, so that's off on the side. The next one is Tiazam. I don't know how to pronounce these things. So this is it. So this one is a calcium channel blocker, and calcium channel blocker falls into two groups. So you have non-dihydropyridine, which this one falls into that group, and then you have just which we have a card on that later. So this one is a non-dihydro, and it's going to lower contractility. Not going to be contracting as fast. It's going to prevent that from increasing. It's going to prevent my heart rate from increasing. And it also works by decreasing the systemic vasculature, like systemic like resistance, right? So basically decreasing my blood pressure in a sense. Um there are some oh wait, let's see, what is this used for? So calcium channel blockers are used for angina. It's also used for hypertension, and it's going to be used for cardiac arrhythmias. The adverse effect now are you can get a headache, you can become dizzy, you can become like you will experience facial flushing. So like if your cheeks are gonna become red, right? Become flushed, and you're also there